Let's take a look at his missing spaces and our fill-in. Looks like we've got a temp across the front of these 5 teeth, and we'll just fill in the gaps here. In a perfect world, if we could get some ortho here to straighten some things up, these molars would be great, but generally it's a lot to go through for a couple of straight molars, so likely we'll just restore as is. Okay, so he's got a big space in the 3 site. Tooth number 1, again, is technically slightly in occlusion. You can see here, I'm gonna just open it up. You can see here, he's touching the tissue, but he's also touching the tooth in front. Just let him know this is a tooth that can go if it causes any trouble, but right now it's giving him a slight benefit, so we can leave it alone. So we'll fill in space number 3. We'll fill in space number 11. This space here for the 15 site is just not enough restorative space, as you can see. Again, the 16 space is, barely occluding on the cusp of this rotated 17. So if you wanted to replace this tooth, I would extract 16 and put in 15. But if it doesn't bother him, you could leave that be. Again, rotated tooth 17 for the 18 site. 18 is again, relatively small space. What I would do is here prep off the mesial end of this tooth to just take care of that forward-facing inclination, and we'll have a little more restorative space to be able to get an 18 in here if he's interested. Again, he could live without that tooth because a 15 is not there either. So I put that on the back burner of necessity. And then we've got our giant space in 30. So 30 is an important tooth, but it's, again, a massive space here. So the way we treat that is we'll put the implant as deep as possible to give you your best chance of a deeper and wider emergence profile. If you can, this tooth's kind of beaten up, and we could do a crown on this tooth, and this tooth's kind of beaten up also, and a crown on this tooth, you could take a couple of millimeters forward on those to close up that space. So that'll be my suggestion, but we'll assume treatment planning it for now without moving those teeth at all. So let's look at the scan. All right, so here's our 3 implants set up. Tooth number 3, I'll start with really wide bone, tons of bone, height, width are great. If you just see here, the bone is super dark in this space, which just means it's a lot of marrow there. What I would suggest is go with a wide implant. There's a 5x10, maybe even a WT implant just to get those threads to grip a little bit wider. I'll show you what that looks like. So the Forte line of implants. So the body on all these is 4.3, but as you see, we go as the wider ones, the body stays the same, but the threads get wider. So something like this, I would even put like a 6x10. And you can just see those threads really grab onto that bone and just give you better primary stability. Again, any implant would work here, but just know that that apical portion certainly is very not dense, very porous bone. Okay, moving over to the number 11. 11, I could have got a 4.3 by 13 in here, but I'd be much harder pressed to get a screw retained restoration. This is going to be angled with that apex pushing towards the buccal plate, but still with enough room. And angling the head of the implant in. So you're not going straight up and down the bone, you're angling it in so that you can get a screw retained restoration. So just a little bit of nuance, but it makes a big restorative difference. And finally, our last implant, also complex, is the wide space. So again, we're going to be burying this implant pretty deep. This is a 6x8 implant. Thankfully, he's got a very low nerve and he's got good bone. Looks like he grafted this recently. Definitely would suggest doing this guided because if you see the graft, zoom in here, this is softer bone, it's going to push you into one of those sockets. So if you use a guide, it'll force you right into the center, which for this case is critical because if you're pulled over to one of the sides, it'll make that restorative that much harder. This is about 4 millimeters subosseous, 3.8 millimeters subosseous. That gives us enough restorative room here to create a nice emergence profile to close that space, to not make that a constant food trap. So placing the implant is important to make sure it's dead center, it doesn't push one direction or the other. Depth-wise, really important to make sure that you have enough room to create a good emergence profile. And then profiling this bone when the implant's in, either at surgery, initial surgery, or afterwards, is also really important to be able to get yourself a nice emergence profile. If I get good primary stability here, what I would do is profile it day of surgery, get a custom healing abutment on there so I can reshape the tissue back into the shape of a tooth here. And by the time we heal up, it's an easy restoration. Okay, that's my suggestions.